Good morning. So yesterday we talked about Cor-HepB, how it started and what our plans are overall. Today in this session, I'll take a bit of a deep dive on the partnerships that we are building with industry and with research groups, and some of the projects that are of most relevant for Africa and for this audience. I would start by briefly describing the Be Simple study that we are developing with HepCNet in Ethiopia, the Gambia, and Malawi, where we are involving early career researchers so that we have capacity building embedded into it. We're also working with industry and academic partners, most excitingly with manufacturers of novel diagnostics that are not yet on the market, which I will describe briefly, with industry that produce some of the test kits that we commonly use for hepatitis B care in the region and for access to treatment, and looking at pathways to make access to antivirals for hepatitis B more available, especially as the HIV treatment landscape is rapidly changing. And in all of the three countries that we're working with, we work closely with the Ministries of Health and the National Hepatitis Control Programs, and we're trying to explore how we can get patients to be more engaged. This is a lot more complicated than we thought it would be. So the rationale for the Be Simple study is simple. We've been talking about this since yesterday. About 60 million people with hepatitis B in Africa, less than 1% of them are receiving treatment, less than 5% of them have been diagnosed. And the reasons for this are, like, hepatitis B care remains centralized, complex diagnostic requirements, limited laboratory capacity, especially in rural parts of Africa where most of the patients with chronic hepatitis B infection live. We have a unique opportunity now in the sense that WHO has now expanded their eligibility criteria. There is formal recommendation for how to start patients on treatment using either near point of care test for hepatitis B viral load quantification or ALT completely. And this has value because most of the Ministry of Health in Africa would rely on WHO guidelines to make their own national guidelines. So even though we have had the HepCNet score and the TreatB score and other biomarkers, which we have shown that are very effective in identifying individuals who need antiviral therapy in hepatitis B, unless these are in a formal WHO-supported guidelines, it's a challenge for national programs to take this up. So having the new WHO guidelines is really helpful. And so this kind of like gives an opportunity for us to explore this further to see how can we use point of care tests that do not require electricity, laboratory support, highly trained personnel to deliver decentralized hepatitis B testing and treatment. So that is the aim of this study, to evaluate the performance of new tests and then their feasibility, effectiveness, and cost effectiveness of using them in a decentralized model of care, using only point of care diagnostics and delivered by non-specialists. First, because the tests we want to use are largely not yet approved for clinical use, we have to determine their performance and their usability, and I will tell you briefly about these tests in a minute. And then following that, we will test the feasibility of this model of care, the clinical impact, and then its cost effectiveness through help with the Imperial Modeling Group. So the first phase of the study will be to assess the accuracy of the diagnostic kits, and I will just go through the two kits. The first one is an ALT point of care test. So the guidelines currently rely on, in its most simple form, to at least do an ALT test and a viral load test to identify patients who need treatment if they don't have other clinical signs of cirrhosis or family history or co-infections. But when we assume that these tests are easily available, ALT, as basic as it might be in the developing world, is not available readily in most parts of rural Africa. So we need a point of care test that can bring ALT outside of the centralized labs into the community. And this is what the Burnett Institute is working on. This is the ALT test. It comes with the lancet, with the buffer and everything, a finger prick blood, that goes onto a sample pad. You have the detectors there, the buffer is embedded in it, and then within 20 minutes you have your result. The barrier we have currently is that the test requires a reader for you to know the actual quantified level of ALT. We are working with the manufacturers to see if this can be done without the reader so that we don't need to have any additional instrument for us to have these tests. And we hope that by early next year, we should be able to implement this. So the first phase, we are currently doing this a study in Melbourne, and then we will follow this up with the Gambia and Malawi to directly compare this point-of-care ALT with the lab-based ALT to test its performance in an African population. The second test that we want to use is, we've been talking about this throughout, is the COLDA antigen test, which is a composite marker of 3 hepatitis B-related proteins and has been shown to correlate very well with hepatitis B DNA, better with viral load levels above 2,000, but like not too bad for viral load levels above 2,000. And we found that it has very good correlation with all of the genotypes, especially the ones that are mostly circulating in our populations. And several studies have been done that have shown that this test does work in our setting. So the company that makes it is now marketing the first generation of the Cor antigen test as a highly sensitive e antigen marker with a point-of-care test that can also be done with finger prick blood in the field with results available within 45 minutes. And the company is currently this week in WHO Geneva talking about having this pre-qualified. And this is just a list of some of the tests that we have done, mostly in Africa, to show the performance of the first generation of the Cor antigen test in African populations. And we've shown that it does very well. And it can be a tool to implement kind of like alternative tests for viral load quantification in African populations. But for the context of identifying individuals who need antiviral therapy, we need it to be more sensitive to identify individuals with a viral load of 2,000 and above. And currently we are working with HCPs to further develop this test with 2 main objectives. One, how can we get it more sensitive to identify individuals with a viral load more than 2,000? And second, how can we reduce the test time to get results from 45 minutes down to about 15 or 20 minutes. And this kind of has been stimulated by an abstract that was first presented last year here in COLDA, and I think the paper is now out, led by Louis Downs, where they assessed the performance correlated antigen in an African population and showed that it correlates fairly well with not just viral load levels, but also with APRI score, ALT, and I think FibroScan as well. So we're excited about this, and we hope that similar to the ALT point-of-care test, by early next year, we should have an ALT FibroScan point-of-care test for Cor antigen. Another thing that is important is we have already negotiated with and agreed with the manufacturer that this test would become available to market in Africa for $5 or less, and for the ALT test at $2, depending on where it's manufactured and other things. So barring any nasty surprises in our first phase of the study in terms of determining the performance of these tests and their usability by non-specialist healthcare providers in Africa, we would move on to the second phase, which would be done in primary care rural facilities in Ethiopia, Gambia, and Malawi, where we would have surface antigen testing to determine infection with hepatitis B, following which there will be a simple medical history, physical examination, an additional point-of-care test for HIV, hepatitis C, ALT, and Cor antigen, and we would use this to determine treatment eligibility, entirely based on the WHO 2024 guidelines, but with replacing of hepatitis B DNA with Cor antigen alongside clinical assessment results. All patients would be followed up for about 2 to 3 years to assess treatment adherence, retention in care, and short-term clinical outcomes. We would also take in patient-reported outcomes and preference of the healthcare providers in using this point-of-care based test compared to the standard of care. So we're excited about this. We hope that by next year, COLDA, we should be able to start giving you some results. I have 1 minute left, and I want to use it to just quickly tell you about a second study that we are setting up through Cor-HepB, which is a phase 1, phase 2A double-blind age de-escalation trial for hepatitis B birth dose vaccination administered using microarray patch technology. We quickly saw this yesterday, but the whole objective here is that the Vaccines Innovation Prioritization Strategy, which is a framework of Gavi, Gates, UNICEF, WHO, and PATH, have identified microarray patch technology as having the highest innovation prioritization to overcome the immunization barriers that we currently have. And they went further to rank which diseases would we have the most impact on hepatitis. We made it onto that list. Currently, the technology is being developed, but most of the interest is around how we use this to deliver influenza vaccines measles and rubella. And there's already an early trial which was completed in the Gambia that showed that you can use the MAP technology to deliver measles and rubella vaccines. So the objective here is how do we make sure that hepatitis B is not left behind, because initial modeling work done by Nick Scott and the Bonnet team has already shown that even though MAP vaccines might be a bit more expensive than the birth dose vaccine using conventional needle and syringe, it can be cost-saving to use a microarray patch technology, given the reduced cost in storage and kind of like transport of the microarray technology. So the objective of this trial is to demonstrate that the technology can be used safely to deliver hepatitis B vaccines, and that it can be used to kind of deliver vaccines at a younger age. So far, the studies that we've had has only tested the MAP vaccination in infants as young as 9 months. So we want to bring this down further to the age groups where hepatitis B vaccines are delivered, which is at birth and at weeks 4, 6, 10, and 14. And then to further do this cost-effective analysis to see like how will it be most impactful. And we expect that hopefully if this thing works, like it can overcome most of our barriers to timely birth dose vaccination, especially in out-of-facility deliveries. I'm out of time now, so I'm going to stop here, and hopefully we can discuss further in the Q&A. Thank you.